Hi, I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention, and I am beyond pleased to join today Dr. Bernadette Melnyk, who has the longest bio that I've ever read. So many titles, so many accomplishments that we can't name all of them. I commend them to your attention in the program book. And I want to mention just a few. Bern Melnyk is the former dean of the College of Nursing at The Ohio State University, where additionally she served as university vice president for health promotion and chief wellness officer. She is the founder and past president of the consortium for building healthy academic communities. She's a journal editor. She's an elected member of the National Academy of Nursing. She is a task force member, past task force member on multiple very important and change producing committees. She additionally is the founder and CEO of Cope to Thrive. I'm especially pleased that she is the chair of the National Forum for Heart Disease and Stroke Prevention. And I think my favorite introduction of Bern Melnyk was the one that Dr. Oz gave when he opened his keynote address at the National Forum's 2025 annual meeting. And he started off by saying, Bern Melnyk, can't say no to her. That certainly is true. And Dr. Melnyk, we need to marshal that kind of conviction and that kind of influence as we work together and we engage National Forum members and stakeholders in joining forces to improve the uptake of evidence-based guidelines and evidence-based practices. I know you're a worldwide leader in the adoption of evidence-based practices into nursing and into healthcare. You're a professor emeritus in both the College of Nursing and the College of Medicine, so you cover healthcare very thoroughly. This is part of our series of conversations with clinical leaders in different types of practices, different settings, on how we shorten the distance between diagnosis of cardiovascular health risk factors and disease and successful management thereof. And I know this is a passion of yours, so I'm really pleased to have you here today, Dr. Melnyk.
I am delighted to join you in this conversation, John, and I am so blessed to chair our fabulous national forum because truly it's making such a positive impact in communities across the United States.
Well, thank you, Dr. Melnyk. Bern, what role do nurses play in helping patients move from diagnosis or screening to treatment? And especially, what role do nurses play in setting patients up to be successful in their course of treatment?
I first want to say nurses are the key to solving the hypertensive crisis within team-based interprofessional care. We currently live in a sick care, crisis care, healthcare system. I'm not saying we don't need good sick crisis care. We will always need that. But unless our healthcare system really begins to invest more in prevention, in early chronic disease management, it's going to be tough to move the needle. We have nearly 5 million practicing nurses throughout the United States. They are usually the first contact for the majority of patients across all types of healthcare settings. Now, the key, though, John, I firmly believe that the central struggle in this whole public health crisis is not in identifying cardiovascular disease. It's in sustaining behavior change and adherence to medication once diagnosed. Nurses are the key to solving those issues.
Dr. Melnyk, you just used the term behavior change. I know we often hear in conversations related to medication adherence, comments and perspectives that tend to blame patients for not adhering to their medication regimen. When you say behavior change, whose behavior are you talking about?
That's a great question, John. I'm talking about both patients, because let's face it, most people don't change behavior unless they get sick or a crisis happens. And that's why when I work with people on behavior change, I always combine evidence on that topic with emotion, because most people don't change unless they get emotionally motivated. You know my story. I was 15, home alone with my mother when she sneezed, stroked out, and died right in front of me. The saddest part of my mom's story, she had a history of headaches. So she was symptomatic for over a year. And my dad kept begging her to go and see her physician. She did. 1 week before she died, she was diagnosed with high blood pressure, given a prescription for a blood pressure medication that my dad found in her purse after she died. She never took it, but think about how many people we have across the United States with hypertension, and only about a third have it under control. See, some of the issue again is people don't feel sick. A lot of people, even if their numbers are greater than 130/80, because that's the magic, right? 130/80.
Indeed.
But a lot of people don't feel sick. They see numbers on paper, their lipids, their blood pressure. But again, we need to figure out as clinicians what is going to motivate people to engage in healthier behaviors, physical activity, healthy eating, medication adherence, because so many people don't. But the second part of your question that I've got to answer is clinicians. We need to help clinicians with behavior change. You know, I'm adamant about evidence-based practice. As you mentioned, I've been working with healthcare systems over the last 25 years to get over barriers, working with clinicians to implement best practices. But that's tough. We're still at a state where it takes 15 years once a guideline is published once new great body of evidence comes out to make change within practice settings.
So, Bern, you've been in organized medicine. You've been a leader in organized medicine for, I hope I don't offend you by saying a few decades. You've been around the track. Based on what you've learned, where should we start? Where can National Forum members make a difference in helping affect those behavior changes, particularly among clinicians? How can we bring those about?
Just like dealing with patients, you got to make it emotional for clinicians too. They have to believe in the change, and you've got to have good evidence to support the change, or people aren't going to make it.
Mm-hmm.
But I've delivered keynotes over the past 6 months where I actually ask participants, and these are all clinicians, how many of you have seen and read the new ACC AHA guideline
On high blood pressure management?
on high blood pressure management? Honestly, only about 15 to 20% of hands go up. So that guideline has been available for 9 months, but we got to do a better job at simplifying the guideline, making it more succinct, really taking such key pieces, bulleting them. Because face it, John, 40 to 60% of clinicians are burnt out. That's the latest statistic that we are battling right now. When clinicians are burnt out, their judgment isn't quite there. Their motivation, their ability to really be fully engaged isn't there. And if we throw huge guidelines onto clinicians, and believe me, I was on the committee, and it is a fabulous evidence-based guideline. But we've got to simplify the recommendations. We've got to make them digestible so people can implement them. And a nice example that I want to talk about is the beautiful shared decision-making tools. They are great resources. In evidence-based practice, we teach it's a combination of the body of best high-quality evidence in combination with the clinician's expertise and patient's values and preferences. We've got to remember there's a sizable amount of our population who still struggles with health literacy. So if we can use tools like our shared decision making tools with our patients, we now have growing evidence at Mayo Clinic that outcomes are much better. So again, we need to provide easy, digestible tools for both patients and clinicians, and we have to have continuity of care.
Bern, the shared decision-making tools, and I appreciate your raising those. The ones that you're talking about are the ones that I think were produced by the Value and Access Collaborative, about 20 or so organizations, different clinical and patient and public health organizations who co-branded them. Is that correct?
Absolutely. Those are great tools. And
Okay,
again,
so there's a link to those in the materials that go along with this interview. So please check them out, and more importantly, put them to use.
absolutely. Getting back though to nursing, John, nurses are great care managers. They know motivational interviewing, which is a technique to help people with lifestyle behavior change. They are well steeped in social determinants of health that need to be built into care plans for people. There needs to be frequent follow up with newly diagnosed hypertensive patients. Nurses are ideal to do that. They are skilled again in behavior change, in case management, in bringing in patient preferences and values. Nurses can lead hypertensive clinics, but as far as policy goes, we need policy and practice change for nurses. All nurses need to be able to practice at their full scope. We still have about half of our states where nurse practitioners cannot practice to their full scope. These changes need to happen. If they happen, these policy changes, these practice changes, we could be well on our way to solving the hypertensive crisis.
Bern, I'm really glad you're bringing that up because policy change is something that National Forum members can work together to affect. You're casting this at the moment for obvious reasons. We introduced you and your very strong background in nursing. Um, is this something that's limited to nurses, this inability to practice to the full scope or full limits of training and capabilities, or does it extend beyond nurses?
It extends beyond nurses. Physicians' assistants are still struggling with this. And think about this, John. We have nearly 500,000 nurse practitioners who are practicing across the United States, whose scope of practice and physician assistant to practice is limited. We have a long history with nurse practitioners and PAs assuming so much care in rural parts of this country where they can be first line again to this hypertensive crisis. So we need policy change for sure. There was a new ruling, I'm sure you're familiar with this, that nursing was just classified as a non professional degree. That's going to hurt our profession. We are already short nurses and nurse practitioners. So, again, we have to remove these barriers. We really do, if we're really going to make rapid progress.
Yeah, and Bern, we know that the evidence showing that when people receive team-based care, their cholesterol control improves, their blood pressure control improves, their diabetes or blood sugar control improves, their medical outcomes improve. So that evidence is abundant, and yet you're describing policy barriers or system barriers to people having access to that kind of team-based care, to having robust team-based care. What do we need to change there? How do we unshackle the members of the team so that patients can fully benefit?
For one, we know, as you say, the evidence is so strong for team based care. We have so much quality data that shows involvement of pharmacists, involvement of nurses, community health workers, the whole team. Outcomes are better. Now, I want to really put a call out now to leaders in both policy, leaders in education, leaders in our healthcare systems. You can create these priorities for change. You can establish a vision within your healthcare system. For one, all your practices are going to be evidence based, and make sure your clinicians are up to speed on how to deliver evidence based care. John, you might think, well, don't we teach that in medicine, nursing, social work, in every program? Yes, it's being taught, but we have competencies for evidence based practice that are not met by the time a lot of people graduate from their programs. So, again, leaders across education, practice, or healthcare systems, we have the ability to set the vision, to set the expectations. And unless we provide resources and support for these things, not a lot's going to change.
So, Dr. Melnyk, are we talking about curriculum changes? Are we talking about simply changing priorities? Are we talking about incentives? What things need to shift in order to solve this problem?
We're talking across all settings. We're talking policy, education, research. I mean, we've had research budget challenges, character builders is what I call them. But we need to make hypertension control and prevention a priority for research funding. We've got to place bigger emphasis in it in our educational curriculums, along with evidence based practice. And we have got to invest in the well being of our clinicians. Because getting back to the point I made earlier, 40 to 60% of practicing clinicians across disciplines, they're burnt out. So, unless leaders are willing to invest, and I talk about this all the time, and I show leaders the return on investment because there's a positive return on investment and value of the investment for investing in evidence based practice, clinician well being. But again, so much of this, yes, does it fall to the grassroots? But the grassroots, the everyday clinicians, the interprofessional teams, they need supported and resourced by top leaders to get this done.
Dr. Melnyk, we're coming up on the end of our conversation, unfortunately. But I want to drill down for just a moment on the point you just made about return on investment. We know, and by the way, as Dr. Melnyk said, there is loads of very good research that shows that team-based care works, it's effective, it's cost-effective, and that and similar research findings are available at multiple places, but a one-stop shop for that is the communityguide.org. That's the home to gold standard systematic reviews of evidence, and you can find the facts there. And they show that among the things that they find is that the things we're talking about, these systems changes, are cost effective for society. But often there's a disconnect between, what we call the wrong pocket problem between society benefiting versus a care delivery enterprise. So when you're talking about ROI, Bern, is there research, is there evidence that shows that a healthcare delivery system benefits financially as well as in the quality of care that it's providing when it delivers
At,
team-based care?
there, I'd have to look at the literature specifically, John, for team-based care. But I can tell you, for evidence-based practice, we showed through our recent published scoping review that evidence-based practice leads to a positive return on investment. And then beyond return
For the institution.
Yes, for the institution.
All right.
It's the same thing with wellness. An investment in clinician well-being leads to a positive return on and value of investment for the institution.
All right. So I think some key takeaways here are that team-based care works very well, and it can help solve the problems related to non-adherence or under adherence to treatment regimen, that clinicians need to be unshackled, if not fully empowered, so that they can deliver, all the clinicians can deliver to the best of their abilities what they've been trained to do, the kind of care that improves patient outcomes and that makes the whole system operate more effectively and efficiently. And those require some policy and systems changes. Is that correct?
That's correct. And John, I must add one important last thing.
Please.
We have to integrate mental health into the care of people with high blood pressure. The latest guideline, we finally have stress as part of the guideline. And there are simple evidence-based practices to help people, both clinicians and patients, to reduce their stress. Our national forums move with the Mayor Initiative, which is making such a positive impact in so many communities across the United States. We have a new beautiful toolkit, and part of that toolkit is a couple simple best practices for stress. But we must screen for mental health issues. Stress, anxiety, depression not only affects people's quality of life and blood pressure, but it affects their ability to adhere to medication and to do healthy lifestyle behaviors that we know will reduce high blood pressure.
I'm so glad you brought that up, Dr. Melnyk, because you're right. The evidence is abundant now and growing seemingly by the week that mental health and cardiovascular, cardiometabolic, other types of physical health are interlinked, inextricably linked. One affects the other. And so it's incumbent on the system, on individual practitioners, policymakers, those who empower not only providers, but patients as well to take that whole picture approach and recognize that mental and physical health are tied together. Well, Dr. Melnyk, this has been a real treat to chat with you. Appreciate you sharing your insights and your prescription for making the system work more effectively for more people so that everyone everywhere can enjoy optimal cardiovascular health, metabolic health, renal health, brain health, mental health, kidney health. Um, we have a lot of opportunities ahead of us, and I'm glad you've helped us see how we can overcome the character builders.
Absolutely. And what I want to finish is by saying an ounce of prevention is worth a pound of cure. Please, everybody, help us put more energy into prevention and early treatment. I believe we can do this, but as a team, because together everyone accomplishes more.